Colleagues, welcome to the Global Coalition to Address Synthetic Drug Threats. I am Brian Morales, and this is Subworking Group 1.1, May 16th, 2024 session. And I am going to share my screen so we can get started. Okay, here we go. Today's session is a special session. We have civil society participation. I want to thank all the civil society participants that have joined the call today. I want to also thank the Vienna NGO Committee for past work over the recent months in organizing civil society organizations and hosting meetings and providing recordings. We will be receiving more content on our website that reflects the ideas, recommendations, experiences of the civil society partners over the past months as we've proceeded with the coalition discussions. I will also highlight that this session only includes presenters from civil society organizations, but we did not open up this session for a broad range of participants from civil society organizations. So those that are representing civil society are here in a participatory role, and we do also still have some government representatives speaking. But all of the other participants that we have on the line will be government representatives per our usual practice. And also, we will be recording only the presentations as per usual practice, but not the discussion. So I wanted to highlight that also, that we'll stop the recording when we get to the discussion phase. Now, this is a special time for the coalition as we enter the implementation phase. This will continue through the month of June and July, as then we move on in August to the review of sustainability and looking at the initiatives moving forward throughout the month of September. So for this month, we are now asking coalition partners in this phase of the coalition to begin reporting on actions that have been taken to address synthetic drug threats. And so we have been reaching out to you through our US embassies. We have reached out to foreign ministries to request those actions formally. And we are also sharing, by way of this presentation, the reporting process with you today. We're also going to be sending you all an official letter requesting a report of your actions, and I'll describe a bit what that looks like in a minute. And those actions, our intention is that they will be shared on our website, and also some of the content may be shared in the Year 1 report that we are looking to publish and disseminate in September at the UN General Assembly. So what actions can you report? Well, the first thing that you can report is any new practice, policy, strategy, regulation, or law that has been taken from the period of July of last year, when the coalition was initiated, through September of this year, anticipated when the coalition Year 1 comes to an end. Secondly, any new engagement or collaboration with the private sector that has already been launched or is about to be launched over the coming months can be reported as an action. Third, any financial support that has been provided by your country, either bilaterally to another country or to an international organization, or any in-kind assistance that has been provided to build a country's capacity to advance a synthetic drug initiative. Fourth, any regional or global meeting that your country has hosted or is preparing to host by September on a topic of interest to the coalition. Fifth, and this is the menu, the 120 plus initiatives on our website, an expression of interest in any of those specific initiatives, the participation of your country or yourself in a global or regional network for collaboration, peer learning, or information exchange. And finally, any other act to strengthen your country's response to synthetic drugs that are consistent with the recommendation. So the report that we are asking can cover one or more of these areas. And again, the intention is to publish this on our website and components of this in the final report. So here are some guidelines for submitting the report. We're looking for a length of up to 2 pages. In the Microsoft Word or email format, we can just copy and paste it that way. And as for deadlines, we're asking for you to submit it to us by the 3rd of June so that we have enough time to review, format, edit, and compile all of the responses. So we're asking you to email the submissions to us at syntheticscoalition@state.gov. You may send it to us in English or in another language. Next, I want to share with you that the recommendations for the coalition have been posted on our website under the timeline section. And so please check that out if you haven't done so. And finally, I'll say that this is the last opportunity to present. If your country is interested in presenting, if you're interested in presenting a best practice and experience in the coalition, this is the time to reach out to us at syntheticscoalition@state.gov, because we only have the months of June and July. And then, as I mentioned, we're moving then the program forward to its year 1 conclusion so that we can then get started with the implementation phase in year 2. So please reach out to us if you are interested in presenting. And that's it for me. If there's any questions on the report and we have time at the end of this session, we can address them. Otherwise, we will take your questions at syntheticscoalition@state.gov. I am going to stop sharing my screen now, and I'm going to turn it over to our co-chairs for today, Ivana and Maria. I see them on the line. Maria, over to you. Thank you so much.
Thank you, Brian. Thank you, Bill, and good day, everyone. Our warmest greetings to the officials from ESINL, Colombo Plan, Dangerous Drugs Board, and our colleagues from different parts of the globe. Welcome to this meeting of the sub-TWG 3.1, Preventing Drug Use. For this session, we will be presenting strategies and best practices on how countries such as the Philippines, academe, civil society partners, and international organizations such as CADCA align their efforts to the recommendations of the Global Coalition, particularly recommendation number 28, of course, which is to develop, identify, appropriate, adopt, or expand evidence-based drug policies and targeted prevention programs in various settings. On recommendation number 31, which is the promotion of prevention at the local level as part of a comprehensive prevention system, providing information on the population substance use and the preventive capacity of the area. And on number 32, which is to encourage the monitoring and evaluation of programs and strategies and foster the exchange of best practices among stakeholders. It's inspiring to note that strategies are cross-cutting on the various recommendations, which for our presenters today are already being implemented and being scaled up, and networks are being expanded in their areas of responsibility. So I will now turn over the floor to my colleague, Ivana Thurston, to introduce our speakers for this session. Over to you, Ivana.
Thank you, Dr. Dumlao. Good morning, everyone. So our first presentation will be from Dr. Le from Philippines. Dr. Le obtained her PhD in Educational Psychology in Human Learning and Development from De La Salle University, Manila in 2017. She is currently the Dean of the School of Education, Ateneo de Zamboanga University, located in Zamboanga City, Mindanao, Philippines. Aside from her professional work in the academy, Dr. Le is a master trainer for the Universal Prevention Curriculum, Practitioner Series core course, School-Based Prevention Interventions, and Monitoring and Evaluation. She also served as a course developer at the English version of the UPC core course on the health knowledge. Her presentation today is titled Strengthening Prevention Through Collaboration and Networking. Dr. Le, over to you.
Hello, everyone. Good day. Allow me to share my screen. All right. Good morning, everyone from the Philippines. I'd like to start with an adage that says, prevention is better than cure. I would say when we talk about prevention or substance use, both prevention and treatment should be present in any country. But it is high time that more and more communities invest in evidence-based prevention. Today, allow me to present 4 different modalities of delivering the Universal Prevention Curriculum Core Course, aiming at strengthening prevention through collaboration and networking. First, let's have a quick review of substance use prevention. Usually, when people hear about substance use, their initial reaction is to provide treatment. But every year, as there are more and more substances that the youth are experimenting with, there is a call to strengthen substance use prevention as well. So, what is prevention? It is the application of prevention science to address the health and safety of individuals through improving socialization and socialization processes to enhance self-realization and participation in society. In prevention, we discuss how we can leverage socialization agents in different settings such as the family, school, workplace, community, environment, and even media to aim for the healthy and safe development of children and youth and realize their potentials as contributing members of their community and society. So why is it called prevention and what do we prevent? We aim to help people, particularly children and adolescents, to avoid or delay the initiation of the use of substances, or if they have already started, to prevent them from being dependent on these substances. Now, one important step to promote substance use prevention is by professionalizing prevention practitioners such as teachers, counselors, human service professionals, social workers, health workers, community workers, and leaders through continuous training and eligibility exams. Now, in terms of training, the Universal Prevention Curriculum Practitioner Series offers prevention professionals the opportunity to learn necessary knowledge and basic skills related to the science of prevention. The core course is the introduction to the Universal Prevention Curriculum for Substance Use, or what we simply call the UPC, which was developed by the Bureau of International Narcotics and Law Enforcement Affairs, INL, U.S. Department of State. The series was created by the Applied Prevention Science International and published by the Colombo Plan Drug Advisory Program. So why the UPC? With the UPC core course, prevention practitioners will gain better understanding about the key elements of evidence-based prevention and the most effective interventions currently available. On the screen, you see the first and second versions of the United Nations Office on Drugs and Crime International Standards on Drug Use Prevention that serves as the guidebook in implementing evidence-based prevention interventions and policies. Here is a preview of the UPC core course. It starts with a trainer introduction and then moves to Module 2, discussing the physiology and pharmacology behind substance use to give some basic information of the substances and how they affect the brain and body. In Module 3, on the critical themes, this serves as the basis of the UPC. Module 4, Prevention Science, Definitions and Principles, will enhance understanding of the science that provides the foundation for evidence-based prevention interventions and policies. Module 5 is an overview of the leading theories that provide an understanding of how prevention interventions are developed and how they work. Module 6 explains how evidence-based prevention interventions and policies were identified by UNODC when they produced the International Standards on Drug Use Prevention. Modules 7, 8, and 9 focus on the relevant skills and competencies for evidence-based interventions. So here, participants learn about the implementation cycle. They also learn about specific skills needed for prevention work and the code of ethics, the ethics underlying various aspects of prevention programming. At the end of the core in Module 10, participants have the opportunity to plan how to apply what they have learned in practice and to craft a professional development plan on strategies for the future. So what's next after the core course? After completing the UPC core course, prevention professionals have the opportunity to be trained in a specialty track that is more aligned with the kind of work that they do. There are 7 specialty tracks, namely family-based prevention, school-based prevention, workplace-based prevention, environment-based prevention, media-based prevention, community-based prevention implementation systems, and monitoring and evaluation of prevention interventions and policies. These specialty tracks are delivered by a pool of master trainers coming from different parts of the world and have different professional backgrounds and qualifications. Now, the question is, how can the UPC core course be delivered in your particular country or community setting? There are 4 different ways to choose from. We have in-person trainings, synchronous online sessions, online instructor-led training via a learning management system or LMS, and hybrid training. So allow me to share my personal experience on how we were able to deliver the UPC core course through collaboration and networking. The first one is the 6-day in-person training, which is the original design of the UPC core course. The entire training is packed with group sharing and activities where participants get to practice skills together and brainstorm on issues while benefiting from the feedback of peers and master trainers in real time. The photos that you see on the screen are from the in-person training we delivered to health personnel and officials of the Department of Education from different regions here in the Philippines, sponsored by the INL and Colombo Plan Drug Advisory Program. However, during the height of the pandemic in 2020, in-person trainings were not allowed. Yet, this did not deter the INL in supporting the online delivery of the UPC through the Colombo Plan and the Inter-American Drug Abuse Control Commission of the Organization of American States, or OASCCAD. One way to do this is through synchronous online sessions, which is a series of regular sessions via Zoom and sharing of course content materials via the Google Classroom. In the first photo above that you see on the screen, we delivered the UPC core course for personnel from the Philippine Drug Enforcement Agency and the Philippine National Police. Here, we met the participants for 3 hours, 2 times each week for 5 weeks, maximizing the use of breakout rooms and other engaging online web applications such as Kahoot, Jamboard, Padlet, Mentimeter, and others to spark interaction among participants. In the second photo below, organized by OASCCAD, we delivered the UPC course for 1 hour and 30 minutes every day for 24 days, and our participants were prevention professionals from the Caribbean countries. Now, what's common between the two were the regularity of the meetings, making the sessions more structured in terms of time, and as trainers, we had to be accessible to the participants through messaging applications like WhatsApp or Messenger, and even Viber as part of the mentoring process. The third modality offers a more flexible approach for the participants through the online instructor-led asynchronous training. In this format, all course contents are learned asynchronously for 10 weeks through the Health e-Knowledge platform, a learning management system hosted on Moodle where participants watch lecture videos, read training materials, and do individual activities on their own time and pace, as well as attend 4 online synchronous sessions on Google Meet, Zoom, or Microsoft Teams to deepen the content through group interaction and activities. Now, during the height of the pandemic, participants needed to register first to the International Society of Substance Use Professionals, or ISUP, so that they can enroll in the Health e-Knowledge course. Because of the nature of this format, the training team is composed of a course coordinator who ensures that participants are on track and issues are addressed in a timely manner. We also have a course instructor who manages the content side of the training and giving of feedback to the participants. And we have a tech support member to help the participants navigate the Health e-Knowledge platform. Because this modality is less structured in terms of time than the regular synchronous meetings that I shared earlier in the previous modality, participants in this kind of modality have to be motivated, to be self-motivated and disciplined to complete the modules within the set time frame in the agenda. Now, what's unique about this modality is that the participants register as individuals and not as organizations. Hence, the mix of participants in a cohort come from different parts of the world with different backgrounds, providing rich perspectives during discussions. The scheduling of the synchronous sessions may sometimes be challenging because of our different time zones, But with proper planning and timely communication, everything works out well in the group. Lastly, I also tried delivering the UPC core course in my own institution, Ateneo de Zamboanga University, in a hybrid approach last year through the support of the Colombo Plan Drug Advisory Program and the International Consortium of Universities for Drug Demand Reduction, or ICUDDR, and the Dangerous Drugs Board in the Philippines. Now, just a quick background, our university has a student population of over 6,000 from the basic education, higher education, and professional schools with over 800 employees. The participants you see in the photo are faculty and staff from the basic education and higher education units. To give you a background of where my university is located, look at the map of the Philippines on the screen. Now, do you see this red circle over the southern part of our archipelago? That's where I currently am. We have the geographic disadvantage, given that there is less opportunities available in our region for trainings on prevention. But having this in mind, I use technology to bring another master trainer from Manila, which is the capital of the Philippines, through a hybrid learning setup. So the participants from our school enrolled in the Health e-Knowledge site and completed the course asynchronously for 10 weeks. Now, in between the 10 weeks, we had 4 in-person meetings where the master trainer from Manila was delivering the main content online, while I served as the in-person course instructor, facilitating workshops face-to-face in between lectures of the online trainer. In this kind of setup, the equipment needed to be prepared and tested ahead of time. Although preparation required work in a hybrid setup, the participants appreciated that time and space were structured in-person sessions where they got the opportunity to do group activities, similar to the first modality I shared earlier, which is the original design for the in-person training. In summary, there are different modalities that any organization can choose from to deliver the UPC core course. Before I end, I would like to share some insights from my experience delivering the UPC core course in different modalities. First, substance use prevention discussions hardly enter conversations in different settings, such as family, the academe, school, workplace, and the community. I realized that many people are still not aware that there is a science behind substance use prevention. In relation to this, one of the common bulb light or aha moments of the participants in any training I handle is that prevention programming is not based on gut feeling. There is a science behind it, from physiology to pharmacology to the etiological and epidemiological models, human behavior and motivation, and the implementation cycle. The UPC core course allowed participants to assess and reflect on their own current practices that do not align with evidence-based practices according to the UNODC standards. Also, the UPC core course offers a comprehensive training package, educating practitioners with the necessary knowledge and skills to understand evidence-based practices in prevention. Indeed, the pandemic was not a hindrance for training more and more prevention professionals. And lastly, with collaboration and networking, there is no excuse for not training professionals for prevention. In closing, here's a quote by Bill Gates: "Treatment without prevention is simply unsustainable." Thank you very much for your time.
Okay, thank you, Dr. Lev, for the short but concise presentation. So as we move forward, we now know there are various approaches that can be used for capacity building. So once again, thank you. We will now move on to our next presentation, titled Scaling Up Community-Based Prevention, Leveraging Systems, Structures, and Resources through CADCA's Model for Community Change. The presentation will be presented by Eric Servio from International Programs from CADCA, and Raquel Tolentino, Chairman of AADAC PHL. So over to you, Eric and Raquel.
Well, thank you so much for the introduction. I just want to make sure, is everybody able to see my screen?
Yes.
Okay, perfect.
I mean, you sharing?
I am sharing. Are you able to?
I don't see it yet, Eric.
Okay. Let's see. How about now?
Yeah, it says
Coming.
starting. It says starting. Ah, there we
Yeah,
go.
it is now.
If you can put it in presentation. Perfect.
There you
Beautiful.
go. Perfect. You know, you think after 4 years of doing this remotely to have this down a little smoother. Anyway, thank you so much, everyone. It's a real pleasure to be here. And so yeah, as mentioned, the conversation today is going to be about scaling up community-based prevention. We're going to talk about it in the context of CADCA's model for community change, and specifically as it relates to what we refer to as community coalitions. But as we just recently spoke about UNODC's standards of prevention, you would find a section on this in the international standards on community-based multi-component initiatives. So joining me today is also Dr. Raquel Tolentino, Chairman Emeritus and CEO of ADAC Philippines. So first and foremost, I want to give you a little bit of a background on who we are and what we do. So CADCA is an organization that is community-based. That's our primary audience and focus. But in addition to being community-based, we're also advocacy-focused. We're also data-driven. And central to our work is coalition building. But we're also an association, a membership association of community coalitions. And CADCA exists specifically to strengthen the capacity of local communities to form multi-sectoral coalitions capable of creating and maintaining safe, healthy, and secure communities. We've been doing this now in the United States since the early 1990s, since our inception, and this is uniquely what we do. And we represent over 5,000 community coalitions, all 50 states, US territories, and in 29 countries around the world. And what we do for communities is we equip them with what they need to know and what to do to be effective change agents. And there's two overarching goals for this work. And first is to increase collaboration among groups and sectors of a community for them to develop the necessary social capital to address local problems through community mobilization and civic engagement. But on the flip side of that coin, the other parallel goal is to reduce substance use rates among youth, and over time, by addressing the root causes and risk factors that manifest themselves within the community context and can increase substance use. So in order to achieve these two parallel goals, community coalitions really lend themselves as a perfect vehicle in which that there are a formal collaboration between groups and sectors of a community, neighbors, residents, organizations, institutions, all agreeing to come together towards a common goal of creating a safer, healthier community for all those who live there by sharing knowledge, skills, resources, and rewards towards that end. In order to equip coalitions to be effective in that work of being effective change agents, we have three pillars to our model for community change. The first of which is it takes a winning team in order to have local solutions to local problems. So we recommend that coalitions, in order to have that winning team, should have at least 12 sectors at the table, which are listed here. I won't do a deep dive into all of them for the sake of time, but I will mention that you'll notice youth on this list. And when it comes to youth, it's not just an audience that we want to lecture on drug problems, but we actually want to give them a seat at the table where they can raise their voice, their views and opinions about what's happening. If we want to protect them, we need to know what they know and give them the space to have a voice and an opinion. So the youth are very central to this work. Some of the best coalitions are youth-led and adult-guided. But like I mentioned here, the 12 sectors help us achieve that first goal of increasing collaboration among groups and sectors. However, that's not enough just to increase collaboration. We need to know where we're going and how we're going to get there. And for that, we train them on a strategic planning process, which I like to refer to as prevention, as the science of prevention, as we equip everyday people to be everyday scientists. That one, don't jump to solutions. Start with a comprehensive community assessment, understanding what's happening, where it's happening, why it's happening, and who's most impacted by the problem. understanding your prevention infrastructure and resources. What do you have? What do you need? And get to work in, addressing those gaps, bringing the right people to the table, and beginning a comprehensive planning process that outlines where your community is today and where you want to see it from 3 to 5 years from now, how you're going to get there, what resources do you need, who else needs to be involved. And in that planning process, develop intervention strategies that'll get you to achieve the outcomes that you're looking for and how to evaluate that process. Since this is locally led, locally driven, we have all the sectors and resources that we need at the table and a credible process in place. We'll notice sustainability and cultural competency in the center of this circle. I'd also like to say too that it's also, we want to make sure with a broad-based coalition that we're achieving ecological outcomes, that we're impacting entire populations. So for that, we know services and programs are important. But we want to make sure that the interventions are comprehensive enough to reach entire populations. So for that, we train coalitions on how to implement comprehensive strategies. So we have over here to the right pillar, individual strategies that really embody that in terms of the first 3 strategies. But we also want them to focus on those environmental strategies, which help us to get to, laws and enforcement, changing policies, practices, and systems that really get to addressing access and availability, as well as attitudes, norms, and behaviors. And just to give a bit of an illustration of this, we've got here kind of a community map all the way to the left-hand side there in these 3 pillars in between. So I just to kind of ground this, all coalitions really work with maps. The first part, when we talk about engaging the sectors, it's really conducting that resource assessment, mapping out your prevention infrastructure and resources, identifying, who's in those sectors and how to start reaching them and engaging all those sectors and members in the community, because that's where you're going to find that winning team and the resources you need to get started and to get the work accomplished. But then when we talk about implementing that strategic prevention framework, it's really identifying the what, the where, the why, and the how in terms of how problems are manifesting themselves in the community context. And, if they're going to be addressed, they should be, specific, identifiable, and actionable so that the community can mobilize around those issues and get to work. And again, comprehensive strategies are going to allow the community to organize itself in a way to really get to the root cause of the problem and start to surface those issues and change the conditions on the ground to impact an entire population. Lastly, I want to say in terms of, so this is the model and the approach, but the intent here is to build a community-based prevention infrastructure. In the case of the United States, going back to 1997, the Drug-Free Community Support Act was enacted and signed. And today it is the largest prevention program that we have in the country. And I'll say this, in all aspects of the work, whether in the United States or abroad, it certainly takes partners. We can't do this alone. So under this program, it's housed at the White House Office on National Drug Control Policy, administered by the Center for Disease Control. CADCA is responsible for all training, technical assistance, and support to coalitions in this program. And national evaluation is conducted annually by ICF. For those who want to find out more and learn some outcome data in terms of the 4 core measures, in this case, DFC measures, reductions in alcohol, marijuana, tobacco, and prescription drugs, feel free to visit the whitehouse.gov for more information. And there's 20 years of data going back all the way to 2002. And now in 2005, INL approached CADCA to see if what we were doing throughout the United States with community coalitions could be replicated around the world. And I'm proud to say that working in collaboration with Brian and his office at INL GPP, we've been able to take this model around the world throughout Latin America, Africa, Central, Southeast Asia, where we've developed over 400 community coalitions. And since we're focused on Eastern Hemisphere tonight, I want to highlight just briefly that we're currently working with 46 coalitions in 5 countries in Africa, We're also working in 3 countries, 42 coalitions in Central Asia. We're also working in Southeast Asia and Indonesia and the Philippines, where between the 2 countries, we have 50 coalitions comprised of 2,352 volunteer members, and Albania in Europe, where we have 5 coalitions. I also wanted to mention, you'll see the numbers kind of vary from country to country as we do this work internationally. There's certainly a vision and a trajectory towards scaling up in countries where we're just getting started. Our initial pilot phase is really grassroots community-based training, meeting the community members where they live and where they are, having those conversations about what's happening, where it's happening in their community, and what they can do about it, and work with them to build their coalitions and transfer knowledge, skills, and abilities to be put to practice in their own communities through coalitions established in that initial pilot phase. But then we move to replication and expansion, where we begin to take the coalition model to other parts of the country, where there's now also a peer-to-peer component from that initial pilot phase. One of the things you'll see is Catechus not really opening offices around the world. We're more interested in installing capacity that not only belongs to the communities, but belongs to each of the countries that we work in, as this is adopted and adapted to the context of each country. And through that, we also want to see this get to a national level, where we develop national associations of community coalitions, because that also facilitates working more closely, being that national umbrella organization to work with decision makers and stakeholders at that level for the ultimate goal to be national adoption. And as a catalyst for that, we've been able to do this work to develop associations of community coalitions in a total of 11 countries now. But today specifically, I'm going to hand it over to Dr. Raquel Tolentino so that she can tell us the story of the Philippines in developing coalitions, but scaling this up all the way to working with national decision makers to make it part of the systems and structures within the context of the Philippines. Thank you very much. And Dr. Raquel?
Thank you, Eric. Can you hear me? Please help me with the slides. So good morning, everyone, and good evening to those who are here from other countries. So I would like to share with you the coalition building development in the Philippines and our efforts to work harmoniously with the government. The coalition building started in the Philippines in 2012 to 2015 through the training of communities, where we developed 7 coalitions at the barangay level. And in 2015, we started with the CADCA training of leaders and developed 9 more coalitions at the city and municipal level. From there, we thought of having an association that will serve as the umbrella organization to all the local coalitions to work on one vision, and that is to have a safe, healthy, and drug-free community. And in 2016, we have registered the Association of Anti-Drug Abuse Coalitions of the Philippines to the Securities and Exchange Commission. Next slide, please. Today, we have 42 local coalitions under the umbrella of the association that works closely with CADCA to promote the development of drug prevention infrastructure through the engagement of local government, institutions, and residents. AADAC share the CADCA model, specifically the strategic prevention process, the 7 strategies for community change, and we encourage multi-sectoral participation. Next slide, please. AADAC also provides the following services to our local coalitions and the 8-point program to the partner government and non-government agencies. This is made possible because of our multi-sectoral membership that brings in different expertise. Next slide, please. Let me share a practical example on how we make use of CADCA model to identify and address the drug problem in Purok Sibucao, Barangay Banago, in one of the communities at the Visayas Island. Purok Sibucao is a fish port at Barangay Banago that operates at midnight, and its porters needs to stay awake to wait for the transport of market seafoods. The selling of methamphetamine in the dark streets of Purok Sibucao has been ongoing for years. There has been no sufficient manpower to patrol the area and no police visibility, especially at night, because the whole Purok has no street lights. After the conduct of community assessment, it has been confirmed that the selling of methamphetamine was identified in the dark streets of Purok Sibucao, and as a result, of the coalition's proposal to the new government center of Bacolod, the mayor ordered for the installation of streetlights to prevent drug deals in the area. Regular roving of village guards has also become a practice, and curfew hours are being observed. The coalition conducted drug prevention sessions in the residents of the said community, and due to increase in awareness, the coalition together with the community work hand in hand to ensure that these areas will remain free from any drug-related activities. Next slide, please. AADAC worked closely with the Department of Interior and Local Government on policy development. Here are some of the policies that recognizes the important role of the civil society organization on drug demand reduction program of the country, and at the same time provide fund allocation for its implementation. Next slide. The AADAC Philippines also became part of the Department of Interior and Local Government National Audit Team, the body responsible for the validation and recognition of the local government unit's Anti-Drug Abuse Council functionality. This national audit team is composed of the Department of Interior and Local Government, the Dangerous Drugs Board, the Philippine Drug Enforcement Agency, the Philippine National Police, and civil society organization who works on drug demand reduction, which is being represented by the association. Next slide, please. In the latest DILG issuance, the BIDA program, the 8-point program that the AADAC provide for the local government units are all part of the government's implementing strategies. And the government acknowledges the support of the civil society organization in the whole of nation approach in the fight against illegal drugs. Next slide, please. On capacity development, AADAC have organized 6 national conferences in partnership with CADCA and INL US Embassy Manila. This is an annual event that gathers all coalition leaders for updating, learning, mentoring, and sharing coalition success, issues, and challenges. This is an adaptation of CADCA's annual mid-year training that the AADAC finds very relevant in capacitating its members and enhancing the skills and knowledge of our coalition leaders, including the youth. Next slide. As AADAC became known for its expertise in addressing the local problems in the community, we were also invited by local government units interested in coalition building for technical assistance. Next slide. We also work and partner with private and public institutions like workplaces, schools, and barangays. Next slide, please. AADAC partners with the different national agencies in the country, and we have gained accreditation from the Philippine Drug Enforcement Agency and the Department of Interior and Local Government. We have been authorized to engage in the implementation of the Philippine Anti-Drug Strategy on policy formulation, advocacy programs, and drug demand reduction in all the regions in the country. All local coalitions were also encouraged to get accreditation with the local government units as civil society organization partners for drug demand reduction. The local government units also can fund the community assessment, capacity building, strategic planning, program implementation, and monitoring as stated in the DILG policy. Next slide, please. AADAC receives recognition from various agencies, including the special award given by the Dangerous Drugs Board in 2018 and the DILG in 2020, 2022, and 2023. And just recently, we have one from CADCA for continuously providing support and assistance to government and non-governmental organizations in the field of drug demand reduction. Our coalition became visible and relevant, and our works have been felt and appreciated in the ground. And so our network grew from 7 coalitions in 2013 to 42 coalitions in 2023. And thank you for that opportunity to be part of the coalitions from CADCA. Thank you.
Okay, thank you very much, Eric. Thank you, Raquel. So we have reached the end of the presentations. So if you have any questions, comments, now is the time to raise them or share them. But may I also remind you in reference to what Brian mentioned at the beginning, if you also have questions in regards to the reports, you can also raise them now. We have about 10 minutes to do so.